So you know what I was thinking? I looked at these slides again this morning, and you've gotten a lot of the content from various speakers. So with your permission, I'm going right to some nuggets and try to almost make this half as long as it would have been, but I still think that you'll have the information that's important to you. Oh, before I forget this, these two articles you should know about if you're in a big, gnarly ER. Big, gnarly ER people, high volume, greater than 60,000. So 2 papers now have come out this in the past year showing the performance limitations of the larger ERs and that you really can't compare them. And if anyone wants them, just email me, and I've got them on PDF. I got one from Jesse Pines and I've got my own, and we'll get them to you. It's nice evidence to have when your CEO is beating you up with data. Why can't you turn your patients around in 120 minutes like the freestanding ER can? So you've got an answer to it. So, and like I say, there's a little tutorial, but probably you're all very sophisticated. It's got so much numbers. It's just the numbers that I thought you might want to have. Sorry, hold on. I am getting to the good stuff. Okay, so we'll just go through some best practices. I want these to be very tangible ideas, strategies that you can take home, that you could think about introducing tomorrow, and it's going to be something for everyone because I've got every volume band in here. So at best practices, most people believe that triage is probably seen its day like in the 80s and 90s when we were all 17,000 visits a year, and they have changed, and so has the facility around us changed. Do you remember in the 90s, you were so proud if you were in an ER that had a gynecology room, an ophthalmology room, an ENT room? No, that doesn't work anymore. We need multifunctional rooms, and we bring the stuff to the patients. And so that's what you're going to have, is rooms that could accommodate anybody within a zone. The other new big concept is to have a zone that is acuity specific, so that you could have lower acuity spaces and higher acuity spaces, and those would look clearly different, wouldn't they? We use an experienced person in triage now as best practice. We're not using the EMT as you used to see days ago. Why? Because we are over capacity a lot of the time, and we need someone to make that really critical decision, sick, not sick, that blink response. And I believe experienced doctors and nurses get very good at that. Another idea, and I just decided about a topic for next year. How about we talk about workforce issues and how the changing paradigms might accommodate this? And I tell you why I say this. We were talking about physician and triage, and it was actually one of you in the audience, an older gentleman, who came up to me and said, you know, I was getting ready to retire, but you know, I really know sick when I see it. I've been doing it for 30 years, and I'm too tired to run around the ER in the back, but I could hunker down out front and say sick, not sick, go to the back, go to the front, and so forth. And so I thought about that as a strategy for keeping physicians in the workforce is as in a physician in triage role. Or, you know, where else could we think about how the changes in the system could accommodate aging physicians? And then, did you know that UC San Diego developed, anybody heard of Jim Killeen and Ted Chan out there? They're always doing very wonkish things with their intake processes and using computers. They were the first group to report on barcoding lab specimens. They now have a self-populating triage. So if you've ever been in the UC San Diego system before, it completely populates that information so that the staff only have to ask you information pertinent to why you're here now. Did you know Toyota does that? I drive a RAV4. When I go in for my little check, everything's on a paper and they say, Mrs. Welch, is everything correct? So how come when someone comes to the ER, we're asking them redundant things over and over in details we should have? You know, don't you people keep any records? And for the amount of time we tend to records, you would think that we would. And then the other idea of abbreviated triage, MedRec, screening for spouse abuse, all this other little added stuff we've front-loaded to the ER visit, put it in the back. Get that stuff on the way out. It does not belong up front. It's not relevant to the immediate care of patients, and it doesn't allow for really facile intake process. And so it's interesting, I've seen ERs go from, like I say, I used to work in ERs. Anybody ever work in an ER where you did 24-hour shifts? When I was a resident, I mean, remember, don't we miss those days, right? I don't think there are any of those very much anymore. And what do you say? 36 hours too. Oh, you got me beat. And how did you know there was there? People would ring a bell, like a hotel bell, to let people know in the back who are knitting or sleeping or whatever know. So now there's phones and there's radios, there's audio cameras often that can tell you. And for a low volume ER, maybe that's how you want to staff your triage. Only certain hours of the day do you sit a body out there. The rest of the day you do it remotely that you can tell that someone has arrived and needs triage. And then I also, as you know, doc and triage and those kinds of intake models are very much where my heart lives. I believe they're very efficient and very appropriate. Okay, a few best practices in radiology, and Pam touched on some of this yesterday. Here's why I believe, and you told me this yesterday, you bear out what I hear in audience after audience, that lab is not the drag so much anymore, it's imaging. So a few things have happened. Any of you have your imaging read remotely, like Australia? Right? Nighthawk maybe? Or to be sure, a lot of radiology groups are reading for a whole system sometimes at night. I know I complain bitterly because Intermountain Healthcare, which has a large trauma center and 5 hospitals in the urban central region, have 1 radiologist reading at night. It does not work. So my x-ray people at my little outlying hospital get the imaging done. I can't get a reading. I wait an hour and a half for a reading. So some things have changed that have led to, I believe, longer turnaround for imaging. And you would have thought they would serve us better, that teleradiography would make it more efficient. It's not always. And the other thing is we have not kept pace. So look at the ER. Anybody been in the ER for 15 years and seen it go through a couple of expansions or whatever? Don't you still have the same amount of radiology you had? Most ERs still have 1 imaging suite for plain films, 1 imaging suite for CAT scans. They go elsewhere in the building for MRI, right? And even when you expanded, and you might have twice as many rooms, you still have the same amount of capacity. So you remember that ER I showed you in one of my earlier talks at the University of Kentucky, the Chandler ER? They actually looked at their data and found that that was, creating a bottleneck and added more imaging. And as Pam said, you can add a tech to transport. That makes it so that your 1 CT scan is going 24/7, and the technician's always imaging and not transporting. But we've clearly seen that we've outgrown. Utilization has gone up, and we've outgrown it as we've added more beds. We've not added more radiology capacity. The issue of no oral contrast for abdominal CTs in the ER. Anybody fighting that battle? Will you email me? This is such a common issue that I had my little firm put together a policy statement that feeds the radiologist literature back to them and makes the case for them not giving oral contrast in the ER that's not needed. They weren't listening to our literature, so now we have to give them theirs. So if you would like that, I've got my most updated version on my home computer. I would be happy to send it to you. I've helped a lot of departments fight that battle that way. So you can go to thequalitymatters.com. That's my website if you want to go there. Or if you can remember my name and how you spell it, it's just sherryjwelch@gmail.com. And remember, any of those goodies that we promised you, Rick had to tell me if I put everything in your book that I wanted to, it would be about this thick. And you can't read a lot of the pages anyway. So just email me if you heard about something, you're like, hey, what was that thing you said about oral contrast? And I'll be happy to send it to you. All right, and then we know now, these were from a little unpublished study we did at EDBA, that you need a certain amount of tech capacity for the ER based on volume. And these were what the best practice ERs showed us, and I think Pam showed you that in a different graphic last month. All right, lab, I don't think that the answer's in on whether a ED fast lab, stat lab, point of care testing, or having an ED lab tech who takes care of all the specimens. I can't find data, I haven't been able to, as to which one is clearly the standard of care for our specialty. I think all of those are options, and I think as your census goes up, you need to choose one of those. Like, you can't have it that every nurse is drawing, labeling, and sending specimens. There's going to be too many errors. You can't have it that you have to wait for a tech to come down. So it's going to be one of those 3. Lab tech in the ER, point of care, lots of point of care testing from that lab tech, or a stat lab in the ER. And you heard about these other things Pam told you yesterday. Tube system, going to make you go deaf, but probably a must-have. There you go. Okay, so discharge, getting them out. I'm talking about discharge not from the hospital as much as discharge from the ER. So some of the things that can really speed this up. Anybody got phone banks where people can make their own follow-up appointments? Anybody doing that yet? So I've seen that. So patients are actually instructed with a little pamphlet to go, because do you waste nursing time or your time scheduling follow-up appointments for your patients? Somebody else has got to do that, folks. We need the highly skilled clinicians, doctors and nurses, practicing to the top of their license. So decide who's going to do that, but the faster that goes and the more you offload it, the more you'll be able to expedite your discharges. Prescription writing is definitely, and I'm not talking about necessarily that you email the prescription to the pharmacy, but just ones that print up really fast. I remember when I was talking to you about working that freestanding ER. It's probably the easiest system I've ever seen. I pick a body part on the computer. I did it the first night I worked there. I'd never seen it before. It gave me some drop-down diagnoses. I touched the diagnosis. It recommended to me a follow-up person and some prescriptions. I'm like, oh yeah, that looks good, good. I clicked once. The paperwork came up, the referral came up, and the prescriptions came up. Is that slick? Anybody have anything that cool? I mean, it was the easiest discharge I've ever done. And so making the back end go faster, you'll get them out faster. And you know what, see if this isn't interesting, and want you to notice this. Look at your tracking board at like 6 p.m. when you're probably really starting to jam in your ER. And it's really fascinating to me because there will be 8 patients that have a queue that they can go, right? Don't you queue some way? If not on a tracking system, you put a chart in a certain box, somehow everyone knows this patient can go home. And don't you know, there's probably just about that number of people waiting in the waiting room. And what's that about? We're just not getting them out. And that's why the whole idea of paying attention to that back door and getting people out who can go quickly to open up the beds is a really good idea. It's not as sexy as talking about boarding, but I think getting discharged patients out is worth your time and attention. Getting follow-up, remember we're talking about closing the loop and not discharging people to the thin air. I've seen places developing an email system for letting doctors know that their patient was seen in the ER the night before. But again, electronic, not taking more clinician time. And then of course case management to help you get people home when they need special things. Then also the idea of a discharge space. Once a patient can go, you've decided they can go, they should not be occupying that bed. You have 1,500 minutes a day of bed time in that stretcher, on that gurney. That's precious to you. You don't use it as a park bench, people waiting. It should always be they're being evaluated or they're being treated, right? Or maybe transported. No one's just hanging out. So as soon as you decide that patients can go, why can't they go to a discharge waiting area? Why can't they pass through a discharge kiosk? In my dream of dreams, they're going to go back out to the waiting room and punch stuff into the computer and get their discharge paperwork there and save on even more man hours. Just simply tracking the time that a doctor flags a discharge and the patient actually leaves, it will get better, right? You know that Hawthorne effect. If you want to track the numbers and start showing people, just tracking that discharge time will make it get better. All right, and then admissions. Do you know the Marriott had bed control before we did? I mean, your average hotel had better systems for managing beds than most ERs do. Right up until a couple of years ago, who remembers this? It's a nurse in a room with a clipboard and maybe a whiteboard managing beds. It should now all be very electronic and very efficient. At the same time that a patient is discharged, the housekeeping gets the cue to clean it, right? Ludi Jagaminas started a policy at Yale, and unfortunately he wasn't here to tell us how he did it, but it's called the no refusal policy. And basically, they were at a tertiary care center. You can see how this is happening because it's happening everywhere more and more. He would make a call to get a patient admitted, and the consultant he called would complain. And, well, no, that should go to neuro. Well, no, that should go to cardiac. That should go to endocrine. That should go, you know. And they had a personal best of a patient waiting 8 hours while the services fought back and forth over who would take them. And so he passed through a no refusal policy. Let me tell you about the version of it on the nursing side and sort of patient flow side and so forth. So I worked with a critical access hospital last year that had trouble getting patients upstairs once they're admitted. And even if it's not very many, these people are very vocal, right? You know this. They go and complain. When grandma was waiting in the ER 3 hours to go upstairs, they complain when they're waiting. They know grandma's staying, they complain. And so we did 2 things. First, we made a no refusal. The CNO, and she was like a commandant. She was like a Nazi. She made it no refusal, which meant when the ER calls you, Floor, I'm sorry, somebody takes report. No refusal. You know, Judy, sorry, pick up the phone and take that report. Just absolutely, she came down on it very hard, okay? We tracked unit by unit how long it took when we asked for the bed till we could get them upstairs. You know who the offenders are, right? Right now you're thinking 5 North and, 7 West or whatever you call your floors. You know who the hardest units are to admit to. So that was huge, and that took about 2 months for her coming down on nursing, tracking their data and giving it back to them. And then we did something else that ASAP would slap my hands for, but I'm going to tell you about it anyway. Have you heard of timed out orders? Have you heard about this? So a set of orders that allow a patient to go upstairs to a bed, and in smaller communities, this really matters. So the doc who's admitting is in his office. It allows the doctor who's admitting to come within 4 to 6 hours. You can time out your orders in any way that you want to, and it allows the patient to go upstairs and get comfortable in a bed and their nurses to start taking care of them. They're pretty generic orders. They're typically passed through an MEC first, and they're not meant to go on forever. They're meant to allow a patient to get comfortable and allow the doctor to come in. I'm sure that people would disagree with me, but I will tell you what, IHI promotes the practice. They're called timed out orders, what else? Express admission orders, I forget, there's a few different terms for them. Bridge orders. Bridge orders is another name you might have heard them under. And if anyone is interested in that, I have some samples from different hospitals. But the combination of tracking the time to get people upstairs, no refusal policy on the part of the staff, and then helping the medical staff, who are very small, to finish their office hours before, or finish up a case in the OR before they'd have to go admit a patient, greatly changed this for them, and they've not had one fallout. They're getting their patients up within 45 minutes routinely now. So just a little. Okay, and everyone familiar with Peter Viccellio's full capacity protocol? Anybody boarding patients in hallways? So this is kind of old news now, but there's lots of data now. Peter has published so much about how getting people upstairs, even in the hallway upstairs, is preferable to keeping them in the ER hallway. So that's the full capacity protocol. And he's actually shown their length of stay is shorter, their patient satisfaction is greater, and they're not having any increased risk. So if you need help with doing that, it's funny, I'm surprised. So many hospital administrators are really averse to a patient in the hallway upstairs, but it's okay to have 10 in the hallways in the ER. So in any case, if you want some information on that. And then I already stole my own thunder talking about timed out orders. More admissions. So we barely talked about this. Everyone familiar with hospital-acquired conditions? There are some things now that CMS will not pay for if they feel that we gave it to the patients. So we're going to be caring about decubitus ulcers, urinary tract infections, MRSA, right? So some people are talking about taking a proactive stance, being a little bit worried that they might get dinged, and wanting to document on arrival if a patient already is colonized with MRSA, if a patient has a UTI, if a patient has a decubitus. So this would mean part of your admission process would be, swabbing their nose, getting a urine, and taking a picture of their bum. So if this is part of your admission process, is this going to slow down everything? And so thus is a revisit of the whole idea of an express admission unit and maybe even an admission team. Could you envision in your ER, if it comes to pass that we're doing all this before they go upstairs, wouldn't you just as soon have a little area that they go into the express admission, like the express, inspection stations you can go to for your car? Get me through that express admission station, do all that paperwork, open up the beds for the ER, get everything done real quick by people who know how to do it efficiently, and then get them upstairs. I think it's worth keeping. Anybody doing those things I mentioned about looking for hospital-acquired conditions and kind of documenting it? Anybody doing that yet? Yeah, it's coming. When I first heard it, I'm like, really? Yes, it will soon be here, because if you're going to feel the sting of readmissions and prolonged admit decision to departure time and so many other things, you've got to start stopping the hemorrhaging. It's like 1,000 cuts. Death by 1,000 cuts, I think, is what it's like for the hospital administrator. So, okay, and anyway, all of these things I sort of already went over for best practices. All right, so some general strategies based on size. What's my source? I don't have one except myself and being in 100 different ERs and talking to lots of consultants. You won't find this. It will get to the literature eventually, but right now this is just, I think, what people who go around and work with ERs trying to make them operationally more efficient know, and now you're going to know it too. So general themes. Higher acuity, Start looking at the next volume band. You know how Jim talked to you about volume bands? So you're at 40 to 60,000, but you have an admission rate of 25%. You're going to start looking early. How are the best hospitals in the 80,000 band, above 80,000, doing things? You're getting ready because the clinical intensity is greater if you have higher acuity. Lower acuity, I have one ER that has just an unbelievable number of kids. Remember, kids, lower acuity, less admission rate, are less sick. So then you're going to almost like look backwards and go towards those service lines that are kind of geared towards lower acuity, various streams of low acuity patient tracks. As the census goes up, the number of hubs go up. How many of you have nice hub design in your ER? You may not, but you know what? You can make one. Remember I told you I've worked in, I believe, the worst designed ER on the planet. And we created geographic zones. It took us a while to get there. But the idea is you're much more efficient as you go up in volume if you dedicate a certain number of rooms, and most people will tell you 8 to 12 rooms, depending on the acuity, is a really nice number to be managing, out of a central station and out of a central team. So you're going to have a geographic zone with a team that includes doctors, nurses, techs, and your own non-clinical people that put in orders and so forth. Does that make sense to you? That you would? How do we know that? Because we know that the most efficient ERs are that sweet spot just below 20,000. Just below 20,000 visits are a very nice place to be. Anybody in an ER like that? It's funny because in our group, those shifts fill up fast. People want to work there because you know it's going to be pleasant. In my view, I think it's partly this, because when it's a small ER like that with 50 patients a day or less, I can touch everything. Everybody I need to talk to, we're all in the same little space. Communication is easier. The transmission of information is easier. And like I say, I feel like I touch everything. It's easy in that venue. Tina, did she get that, Rosefin? Right? Bigger ER with many more beds and many more patients, it's all a lot harder, and the system is less forgiving unless you've got it just airtight, and we'll talk about some of the things that make it airtight. So as your census goes up, you increase your hubs or your geographic zones if it's not, if your building and your footprint doesn't support you. As your census goes up, then now you need to be streaming. And truthfully, I don't care, and I don't think necessarily that the word is in on whether streaming to make equal hubs, or we're just going to treat them like a bunch of little ERs that are the same, or do you want to stream, we're going to put chest pain, sepsis, elderly, really sick, gnarly patients here. We're going to put lower acuity patients here. We're going to put ESI 3 over here. We're going to put chest pain here. So you're going to start doing a lot more patient streaming. And as your admission goes up, then anything that expedites the admission process helps you. More general themes. So low admission rate or high pediatric rate, build out a super track, which is like a super fast track where you just kiss them goodbye, in my view. Fast track where you've got all the supplies that you need for most of the procedural stuff. You can even have a wound clinic. Anybody doing a wound clinic? I say marry wound clinic and follow up IV antibiotics. They could go to a certain place, they're told to come back, and those are two service lines that you're operating concurrently in your ER. And I just gave some advice to an ER that they really, really wanted to have a PEDS ER because they were going to be building a PEDS hospital. But they couldn't populate the space that they had for it. And so they decided to define PEDS as 22 years and under. Does that make sense to anybody? I'm like, oh, because now, right? Now that you've added, which by the way, EDBA, we say 16 and under is pediatric, but once you add 18, 20, 20, now you're doing every kind of GYN case, right? You've totally changed it. I said, why don't you instead keep 16 and under as your pediatric ER and throw in your fast track stuff. Bring some easy fast track stuff. Decide that you'll stream them there. I thought that was a better plan. I'm surprised we didn't mention this, but the whole concept of a geriatric ER, if you're serving a very high senior citizen population, it's really worth thinking about. And there's a whole lot now coming out about how you would design it. It would actually be different. You'd had floor lighting and not so much overhead lighting because of the elderly. The light reflects and makes them fall. You'd have different flooring materials. They call it, I saw an article about a geri patch when they come in. You'll give them big reading glasses because they forgot their glasses. You'll give them a temporary hearing aid that just augments everything. You'll give them non-skid booties, right? And you'll give them egg crates to sit on so that they don't get a sore while they're there. I think this is a great idea. So you could have a geriatric area. These 4 beds are our Geri ED, and be very senior friendly. Everyone would be told to go in the room, shut the door, and talk loud for those patients, right? Because they can't hear. So the idea of this segmentation and segmenting things by age and considering, are you ready for, if not a geriatric ED, maybe a geriatric area. And when you have a high senior citizen population, you're going to want to build out higher acuity service lines, right, and expedite the whole admission process. Oh, here's an interesting thing that I got from the Canadians. I went up and got to be a little advisor to the Canadian government on some of their healthcare metrics. And their early CTEST data showed that there's a senior citizens peak. Do you know what it is? When would you guess? When do senior citizens seem to come en masse to the ER? If you notice that, look, right after dinner, it's because their children have come to see them and say, Mom's not acting right. Or their children have called them, Mom doesn't sound right on the phone, call 911. And so this is very fascinating. Similarly, if you open a fast track, you'll get a little bit of a pediatric surge right when it opens, because the mothers in the community know that they can't get into the pediatrician, so they're going to your fast track at 11 when it opens, or at 1 when it opens. So it's very interesting, some of these demographics, and to sort of plan for what the day will look like. But when you think on it, don't you think about getting a lot of seniors in that early evening time, you know? I thought it was interesting data. And then case management. I had a CEO tell me that he was going to quadruple his case management in his ER because he saw the way things were going. And I said, I think that's a great idea. All right, 20,000 visits, easiest to work in, very forgiving. You touch everything. You're mostly going to do single coverage. There are a few things you can do to expedite it. I believe that this is a good setting for triage order sets, chief complaint-driven triage order sets. You can still probably do traditional nurse triage, the rate that your patients arrive, but maybe pull to full is a better strategy. You can do parallel processes, and of course we consider best practice to draw labs and put in an IV at the same time. Pre-printed discharge instructions can make things go faster. The good thing about those low volume ERs is they have capacity most of the day. They have the capacity most of the day. Okay, this is actually one of the hardest operationally because it's kind of surprising you how busy you are. You go from 20 to 40 and all of a sudden it's a completely different game. Now you're going to need double coverage. For sure, I believe that at the very latest at 28,000 visits, you have to start looking at somebody during the peak hours, and whether you want to put a doc in triage or open up a fast track with a doc, you know, one or the other needs to be considered. And oh, by the way, what if you don't quite need another doctor? Any of you medical directors, you're like, well, we don't really need another shift. Anybody doing that? So the whole idea here will be, let's build out the doctor's capacity. 2 best ways to build out doctor's capacity. 1, what is it? How can you spread your doctor farther in terms of their skills? Scribe, absolutely. So scribe, or the other one, mid-level. That doctor will just oversee and supervise. Those 2 ways are the 2 best ways. Maybe people know others. Those are the ones that I put my money on. I want to build out the doctor's capacity because I'm not quite ready to add another doctor. Okay. And by now, you're definitely overrunning traditional triage, and you've got to do something different. What they did in Pennsylvania is they did pull to full in the low parts of the day, and then when it got busy, they did a team. They had a little team and did team triage and decided who got a bed and who didn't. And so you definitely need different tracks by now. You need an ED lab tech, having nurses draw and run these things. I mean, I still see little ERs. Anybody got one where the nurse will draw the labs and somebody has to walk it to the lab because they don't even have a tube system? Anybody in that dire straits? There's still ERs like that. And now you're going to find that just talking to people isn't working. Now we need something else. So you're going to add radios, and eventually that's going to give way to dedicated cell phones. And by 30,000, I think you're going to need to think of at least some hours of the day with triple coverage. Maybe it'll be 2 docs and a mid-level, but you're going to have to build out the capacity. All right, 40 to 60,000. That's when it gives way to muffin top, right? You're overflowing the top of your jeans, big time, in this size ER. And it begins to be a very unforgiving system, okay? Because you can't touch everything. Anybody worked in an ER and watched it go through these volume bands that we're talking about? It really, yeah, there you go. It really, isn't it a different beast? It's so different than when you started and it was like at 20,000. All right, so now it's the unforgiving system, and you've really got to start look at expediting flow. And so doc and triage and fast track. Maybe you would add a super fast track. Maybe you'd add a clinical decision unit. We didn't talk much about that, but what about somebody who won't qualify? They're not going to be there for, observation, but you're going to need them there for 8 hours, and there are increasingly numbers like that. So you're going to start adding to the patient segmentation. And if you get big enough and you have high enough acuity, you may have clinical decision unit and an observation area. So being willing to sort of see this coming before it's upon you is the real trick, I think. And the virtual bed strategies are a must by now. What do I mean by that? I mean, not everybody gets naked, put in a bed, and laying down. Okay, a lot of them we're going to see, evaluate, begin a diagnostic workup, and have them go and wait sitting someplace, which, oh, by the way, so one of the other speakers said they like that. Especially the seniors really like to just be sitting in a chair waiting for test results. This gives way to the results waiting room area. So when people started, they just cordon off a part of the waiting room and put signage up, results waiting area. But as you get more sophisticated, you'll find space to put them. In fact, I've encouraged this one ER that I'm working with, they've got a number of places where chairs and a television can sit. I'm like, this is results waiting area for zone 1. This is results waiting area for zone 2. Start getting creative about looking at your space. Where can I put some chairs and put some signage and create a flow space for my ER? And keeping track of them, that's another whole issue. You need to really understand how you'll keep track of them in your tracking system as you move them around the department. But there's no reason that someone, I'll say it again, 1,500 bed minutes a day, use them to diagnose, use them to treat. No one uses them as a park bench. Right? So they wait someplace else. By now, in the 40 to 60, you probably got a staffing method that includes mid-level providers and scribes. And you might even need 2 docs at night, depending on what your admission rate is. I like, actually before this, but absolutely by the 40,000 mark, I like a patient flow coordinator. Who knows what I mean by that? Do you want to say in a couple words? I put her on the spot. Here, I won't make you run around the room to do it. Never mind. All right. Just how about the idea that you have a nurse who's not taking patients? I bless your heart for being so devoted there. Because you guys did this, didn't you? Yeah, Deb, they did this in her shop. So it's a nurse who does not have any clinical duties other than to watch the flow in the department, to notice on the tracking system, we're getting backlogged in x-ray. What's going on? We're getting backlogged in labs. What's going on? And so someone to be sort of that watching it and be, kind of the command central, noticing things and tracing down problems and understanding. By now you've got 3 hubs. Remember we said operating in geographic zones, better still hubs. I love them when they're separate. And you're going to see an ER, if you will stay to hear this tour, you're going to see an ER that will show you a fabulous design that's got those kinds of hubs. He calls them bullpens. I don't care what he calls them. They're fabulous. And now here's the other thing that's happening at this point. You need clear ownership of every process. And so do you know what this means? It means cataloging everything that happens in your dang ER all day long and who's responsible for it. So I'm working with an ER that was trying to get a handle on how much on call they're using. How often do they call doctors on call? How often do they have to come in and so forth? And we couldn't get data that was adding up. And so I said, well, who's doing this? Who's doing the log? Well, sometimes Jeannie does it, she's the clerk, but then sometimes the docs do it themselves. And then if I'm here, so can you see what's as good as an answer as nobody owns that responsibility? When you ask a question, who's responsible for X in the ER, and you get the answer, we all do it, right? That's as good as nobody owning it. So for every task in the ER, from urine collection to putting in IVs, from pushing results to doctors, there has to be someone owning it by the time you're at this volume, or it won't work. Anybody got a ship that's operating that tightly right now? Because we're going to come and visit you next year. That's a tight ship, and that's what we need to strive for operationally. And then by now we're clearly paying attention to communication. Let us just say it's a done deal, that we've mapped out our communication strategy. We have our mediums that we use. Everyone knows, everyone's been trained in it, and we know, and there's very few overhead pages and a whole lot of texting and direct cell calls going on. And we also use maybe the tracker for non-acute information. Okay, and then, you already saw this, didn't you? Is this a duplicate, or it's just, it's not déjà vu for me? Okay. All right, so now this volume, up to double dock at night. Double dock and triage. Anybody ever seen a shop that does that? Double dock and triage? So sometimes your census is going to be such where 20 patients arrive at once. So you're going to have to develop mechanisms. So it would be super fast triage, doc out there deciding who's really sick and who has to come back immediately, and probably doing 2 or 3 at a time. Because remember your curve. So if I said to you, you need triage for 36 hours a day, there may be hours when you need no triage because you're so slow, but the evening shift, roughly how many more patients are seen on evening shift versus afternoon shift? So say 4 p.m. to 4 a.m. 4 p.m. is about 400% greater than 4 a.m. It's quadruple, times 4. I don't know if I said that right, but 4 times as many, let's say. In any case, and so the new intake models, you might even have a pod. So the beds are all full. You've done everything that you can, and now you're going to set up a place where you take a triage team and go pod by pod. And Jim Augustine actually did this with a hospital. Tell me if this was not gutsy. 15-bed ER, 42,000 visits a year. Tight? Busy? He said, why don't you create 6 intake chutes, triage bays, little triage pods? Why don't you create that? Would you be willing to have the guts to try that? You've got 15 beds in your ER. Would you give up 6 for intake? Well, he convinced them to give it a try. So now they've got a roving team that's going bed to bed, assessing these patients, and a whole bunch are going to the results waiting room, and very few, oh, by the way, the number's going to be 1/3 or even 20% will actually need a bed. And it worked beautifully. It really worked beautifully. So you're going to use a newer intake model when you get to be this kind of volume. And you can have non-acute patient streams that really can go home almost from the little triage pod. Doctor says, you know what, this is just a pulled muscle in your back. I'm going to write you a prescription. Sit in the results waiting area and we'll get you out of here. Do patients like that? Yes, they actually really do. In fact, I was even surprised. St. Joseph of Orange, when their whole place was full to the brim, it's an ER in California, they took a team to the waiting room. And they went person to person, look, we know this isn't private. If you want to wait for a room, you can. But if you want to, we'll talk to you. Well, I'll talk to you. I'll talk to you, doc. And it was unbelievable. I mean, we talk about privacy, but the patients more cared about timely care. And they actually would talk to a triage team in the waiting room. Okay, and then you're growing your fast track as well during the peak hours. You'll probably move to a 4th work hub. And who's familiar with the idea of the breathing ED? Okay, so the concept is this. If I told you only need 1/4 of your capacity in the wee hours of the night relative to the late afternoon, why should they all be open? So if you've got nice geographic zones, or better still hubs, how about open them up during the day and bring them back at night? From what I've never been to Beaumont, but I understand that that's how they do it. I think they have seven zones or 7 hubs, and they open them and close them according to the day. Suffice to say, 24 hours case management by now, maybe even double staffed. And then dedicated service lines. And like I say, I like the idea of a geographic zone that might have a certain level of acuity assigned to it, right? Because real sick patients, we need really big rooms with open doorways, because as a team sport, we got to run in there sometimes and bring in a whole team and bring in x-ray. The ESI 3s that you still want to do a belly exam or whatever, you need a little space, but you don't need the space you need for the higher acuity. So geographic zones staffed with a team, hubs that expand during the day and then fold back down at night. Is it making sense? Are you kind of getting a vision, almost hearing a rhythm in your mind for how an ER should ebb and flow during the day? Okay, you heard that. And so my point is, don't do this, right? But by knowing what to expect, by knowing where you are, letting your data define you, now you can look ahead and say, okay, you know what, in a couple years, we're going to be in the next volume band. And oh, by the way, we admit almost 30%, so maybe we better start looking at it even sooner. And there's a menu of things that you can choose, and you would choose them based on your acuity and what your patients need from you. And basically, we're not planning our operations by intuition. It really is data-driven. Right, we're using that data and we're making it work for us in how we plan our operations. So, okay, thanks very much. Any questions? I in fact even went over with cutting out half my slides. What are you going to do? You can tell I love the subject. I think it's very interesting. I think it has direct applications. Did everyone get like one nugget to take home? Maybe? Couple? Okay, good. All right.